Okay, so this is mature lymphoid. So yesterday we talked about acute leukemias, and we saw two of the main. We talked about acute lymphoid leukemias and then acute myeloid leukemias. So there's a lot going on with them, right? So now we'll move over to the mature lymphoid. There's some common mature lymphoid neoplasms that you need to know about because you'll probably encounter them in the lab. And they're a little bit different because now they're mature, right? So now we're thinking more of chronic. We're thinking more of mature and maturing cells that are either coming from the bone marrow into the peripheral blood or from the lymph nodes, if it's a lymphoma, right? So typically lymphomas will implicate lymphoid cells, right? Because it's lymphoid tissue. So let's talk about leukemias and lymphomas again. A lymphoid leukemia is identified when there is a malignant proliferation that's happening in lymphoid cells in the peripheral blood, bone marrow, and also in the lymph nodes, okay? So that would be a lymphoid leukemia. So an example of that is chronic lymphocytic leukemia. That's anytime you think of leukemia, think of bone marrow. Okay, it's the bone marrow that's really being affected, but you can see the cells in the peripheral circulation. Lymphoma is recognized when there is malignant proliferation of lymphoid cells in the lymph nodes that may eventually appear in peripheral blood and also in the bone marrow. But the initiation of the proliferation of lymphoid cells starts in the lymph nodes, okay? But then it could go into the bone marrow, it could go into the peripheral circulation, all right? There are two types of mature lymphoid, okay? You have the mature B cell lymphoma leukemia or the mature T cell lymphoma leukemia. So we saw a little bit of that, how they separate them, right? B cell, T cell. Anytime you think of lymphoid, think of the two cells because the lymphoid cells are either B cells or T cells, okay? So think of those. So this is the diagram that helps us understand the proliferation of a lymphocyte, okay? Specifically a B lymphocyte. And so we have to kind of take a look at this because this way we can understand a malignant process like cancer of these cells. And keep in mind that the cell has different markers, right? So throughout the lifespan of the cell, it will have certain markers and then it'll lose some markers, right? Like CD34, right? Remember CD34 is a very immature stem cell marker. If the cell is a little bit more differentiated, it's not going to have CD34 anymore. So we use this a lot in hematology because it helps us tell what is the stage of the cell? What am I looking at? Stem cell, right? Progenitor cell. I'm looking at a more differentiated cell. These are the markers that we use in flow. These are the markers that we need. All right. So B cells have their own little markers. T cells have their own markers. Myeloid cells have their own. Monocytes have their own. That's unfortunately, we do have to remember these CD markers. Because it just give us an idea of the lineage that we're looking at. But it starts to make sense. So don't worry, we're not going to have to do that right now. But eventually, when you read a little bit more about it, it just starts to make sense to you. So it is important to understand lymphoid differentiation so that we can understand lymphoid neoplasms. So basically, as the B cells, okay, so this is B lymphoid differentiation. As the B cells mature, they express changes in their immunophenotype, okay? And each immunophenotype will be a little different at each stage, okay? So when you see the word, the abbreviation BCL, what you see down here, BCL, stands for B-cell lymphoma, okay, and SIG, okay, so it stands for surface immune globulin, okay. There's also CIG, which is cytoplasmic immune globulin. This is SIG, surface immune globulin. So BCL, CD, surface immune globulin, these are all markers that we need to recognize, okay. So now B cells, to understand it, they actually start to develop in the bone marrow, okay? But what's very special about them is that they take on their differentiation in the lymph nodes, right? So it's like bone marrow, bone marrow, bone marrow, but then where they get to the lymph nodes, that's when they start to differentiate, okay, in areas within the lymph nodes. Remember that the lymph node, if you could just try to picture the anatomy of the lymph node is surrounded by a capsule, and then immediately under that capsule, there's something called the cortex, okay? And the cortex, inside that cortex, there is primary and secondary follicles. So primary, secondary follicles, we just need to know where they are because that's where these B cells like to go, okay? The primary follicles have little tiny aggregates. They have cells called naive B lymphocytes, okay? These little B lymphocytes are naive. These are basically the types of lymphocytes that have never been exposed to any type of antigen. So they're naive. They don't know anything, okay? And what they do is they express B cell markers on them. So they express CD19, CD20, and CD5. So CD19, 20, CD5. CD5 it's kind of interesting. So just put a little star next to it, okay? But 19 and 20 is very, very common to have for a B cell. Okay, so then as the cell matures, they move towards what's called the marginal centers, okay? And the cells of the marginal centers have specific immunophenotypes. In addition to the B cell the B cell markers, in addition to expressing the B cell markers, they also express germinal center markers, which are CD10, BCL6, and they lack BCL2. So if you look at here, CD10 is here, that's a B cell marker. BCL6 is also a quote unquote germinal center marker of a B cell, but then they tend to lack that BCL2. All right. And so there are in these germinal centers, there are these dark zones, okay? These dark zones of the germinal centers have what are called centroblasts, okay? And this is an area of the germinal centers within the lymph nodes that has a lot of proliferative activity. There's a lot of somatic mutations that are going on. There's a lot of mutations that are happening, somatic mutations of the immune globulin variable regions, okay? So remember what the B cells do, right? What do? They make immune globulin. So all of that is a whole process that is happening through the development of the B cells, through the differentiation of the B cells. And so in this germinal center, where there's somatic mutations of the immune globulin variable regions, this is where the cell becomes antigen specific, okay? So after some of these somatic mutations have happened, centroblasts differentiate into a cell that's called a centrocyte, okay? But this is also happening in the germinal centers, okay? Centrocytes. Centrocytes have low affinity, and they undergo apoptosis. I'm sorry, centrocytes that have low affinity undergo apoptosis, and centrocytes that have high affinity, they lose their germinal center antigens, right? And then they happen to differentiate into memory cells. So the centrocytes that have high affinity kind of are the ones that will survive, if you want to look at it that way, and then they turn into the memory B cells. And I guess I would say the final stage of B cell differentiation are the plasma cells, right? So the plasma cells, they reside in the medullary cords of the lymph nodes, and these plasma cells can also migrate to the bone marrow. Plasma cells, what's very interesting about them is that they lack they lack the pan B cell antigens, and they express CD38 and CD138 and a surface immune globulin. So if you see them over here, so these CD19, CD20, this would be considered pan B cell antigens, right? Sorry, pan B cell markers. So if you see the naive B cell has 19 and 20, the B cell blast has 19 and 20. Plasma cells don't have that because they are basically very differentiated, but they are known to have CD38 positive and CD38, 138 positive and surface immune globulin. Plasma cells, although they're developing and they're maturing in the lymph nodes, they have the ability to go back to the bone marrow, and that's usually where you would find them, in the bone marrow. But they express CD38, 138. So if you look at the positives and the negatives here, it just gives you an idea of the kind of cell that we're looking at, the maturity of the cell, differentiation of the cell. If I see that my cell is CD1920, CD5 positive, then I'm like, all right, you know, this is more of like a B cell, right? Surface immune globulin. If it's given me a variable CD5, then I may be looking at a B cell of a primary follicle. If you're looking at a BCL2 negative, then we might be looking at a centroblast. If you're looking at the same thing, but more of like a memory B cell, which has a positive for BCL2 plus, then it would be more of like a differentiated B cell, right? So it just helps to have an idea. Morphology would help too, but we can't always see the difference, okay, with these cells. So it could be very difficult because, you know, we don't know the exact stage that they're at unless we do our flow cytometry, okay? So just keep that in mind. There's a lot of stuff that goes on during the differentiation process. An important part of it is the proliferative activity that the B cells have, and the somatic mutations of the immune globulin variable chain, okay? And that's necessary for the immune globulin to have specificity for an antigen, okay? And again, so the centrocytes that have low affinity, they undergo apoptosis, but the centrocytes that have high affinity, they lose their germinal center markers, okay? And then they become B cells. All right, that's going to be very important in just a little while, because I'm going to bring it back up for some markers that we need to know for prognosis in these mature lymphoid neoplasms. All right, so the first one that we'll talk about is called chronic lymphocytic leukemia. Chronic lymphocytic leukemia, again, chronic, so you're thinking more maturing cells. Lymphocytic means lymphoid. Leukemia means it's originating in the bone marrow, right? So you could see it from the name. So it's a bone marrow problem. It's involving mature lymphoid cells. Okay, there's different types of CLL, but this is there's one big common type, basically. Okay. And what happens here is CLL, or chronic lymphocytic leukemia, is characterized by the accumulation of small B lymphoid cells, or small B lymphocytes, in the bone marrow. You see it then in the peripheral blood. You also see it in lymphoid organs. The median age of diagnosis is approximately about 65 years of age. One important thing with this type of leukemia is that we must do immunophenotyping to diagnose the patient. We have to see the CD markers on the cell, okay? The white count, it's pretty high for those patients. It can range between 30,000 and 250,000. And the World Health Organization has come up with a classification criteria for people with CLL. So basically, if your patient fits all of these criteria here as defined by the WHO, you could say it is very likely that this is what they have, CLL. All right, so we're looking for B cell monoclonal lymphocytosis, okay? anything higher than 5,000. So what that means is that you would see your absolute lymphoid count, okay, to be consistently over 5, okay, consistently over 5. There's clonality, okay, so basically the lymphoid cells express either kappa or lambda light chains, okay, that's the term for that is clonality. Okay, there is the co-expression of the CD markers CD5, CD19, CD23, CD20 could be dim or weak, and surface immune globulin that could also be dim or weak as well. And you need to see less than 55% pro-lymphocytes. Pro-lymphocytes are the stage right before the lymphocyte, right? Remember lymphocytes, how they go from blast to pro to mature, right? So there's like 3 main stages going on. So a pro lymphocyte would be kind of like the stage right before the mature lymphocyte. And you must see less than 55, because when it goes over that, you could categorize it as a pro-lymphocytic leukemia, which is fine, but we just need to make sure we have the numbers correctly. All right, so B-cell monoclonal lymphocytosis over 5,000. Clonality, so they're expressing either kappa or lambda light chains. So with that, B cells normally, if it was a normal patient, they express both kappa and lambda light chains, right? But this is an aberrant process. Since this is a neoplastic process, you're seeing clonality. So you're seeing that they are expressing, these B cell lymphocytes are expressing either kappa or lambda. All right, so that's a big clue. That's how you know. You're like, oh, okay, I see either kappa or lambda, so there's something going on here. Okay, and the co-expression of CD5, 19, 23, surface immune globulin, and CD20, and again, less than 55% pro-lymphocytes. So there's 2 forms. There's typical CLL, and also there's atypical CLL. In typical CLL, chronic lymphocytic leukemia, there are usually more than 90% lymphocytes that look very, very small, small to medium, I guess. But they look like they have normal morphology. So with that, I mean, they have the coarse chromatin pattern. They have a very tiny little cytoplasm in there, very scant cytoplasm, okay? And in a CLL, you may see less than 10% pro-lymphocytes present, and that's fine if you see less than 10%. Pro-lymphocytes, we haven't really looked at them. I'll show you. I think I have them in another slide, but pro-lymphocytes are larger lymphoid cells. They have less condensed chromatin, and they do have distinct nucleoli, okay? So they're a little bit bigger, I would say, okay? And the lymphocytes that you're looking at here, they look normal, okay? They look normal, but they're really not, okay? But it gives us the notion, it gives the appearance of being normal. Now, the only thing that wouldn't make them normal is that there's just a high number of lymphocytes. Like normally you would find in a healthy adult, you would find 18 to 42%. And this, in a CLL, it's way higher than that. And another thing to note is that every time you have a patient with CLL, you also see lots of smudge cells. These are called smudge cells. So these are like the nucleus of a lymphocyte. These the abnormality in CLL is that there's like resistance to apoptosis, so the cells don't die, and they get very old, right? They're like old aberrant cells. And because they're older cells, when you make a smear, you smudge the cells. So this is a smudge nucleus, all right? But because there's so many lymphocytes in CLL, you see a lot of smudge cells, because when you make the slide, it just smudges the cells. A lot of people think, oh, I see lots of smudges, so it has to be CLL. Well, that's not necessarily true. This is not a diagnostic criteria, but it's a good visual, right? So if you see lots of lymphoid cells, mature lymphoid cells, and then you're also seeing lots of smudge cells, then yeah, it's helpful, but it's not an actual diagnostic criteria, but it does help to see them and to recognize them. So again, they're just older cells. This is just a nucleus. A smudge cell is kind of like the nucleus of a lymphocyte that you've smudged, but is a good visual for you, because when you see lymphocytes in smudge cells, plus you look at your history, your clinical presentation for the patient, it helps you. Okay, so it can help you with the preliminary diagnosis. Okay, so typical CLL is kind of like the most common. It's seen in about 75% of the cases in people that show this. In 25% of the cases, CLL is seen as atypical CLL. Okay, so it's kind of like a mixture, right? Atypical CLL, it's like a mixed cell type. It shows you more than 50% of lymphocytes they have kind of like this lymphoplasmacytoid morphology, or you can also see cells that are exhibiting lots of indentations or clefts. Okay, and then on top of that, you may still see less than 10% pro lymphocytes. So in this type of CLL, what they found is that many of the cells, about 15% of the lymphocytes here, maybe a little bit more, have like a cleft, kind of like indentation here, I would say, right? Like a cleft on the nucleus. So that's kind of like a characteristic of it being atypical. All right. So, but most of the time, 75% of the time, what you're going to see is a typical CLL, which is what the slide before was showing. Okay. There's also an atypical PLL, which is pro CLL PLL. PLL stands for pro lymphocytic leukemia. Okay, in this variant, there are small lymphocytes and maybe about 10%, but less than 55% pro lymphocytes. Okay, so you would call this kind of like an atypical CLL or PLL. So you see more than 10% small lymphocytes, but less than 55% pro lymphocytes. So pro lymphocytes are these. They're bigger. They look a little bit more, look a little less mature. Okay, they have a punched out nucleoli, so it's very prominent, the nucleoli on these pro lymphocytes, very prominent. And then I did say last time that it's very prominent. Nucleoli is very prominent in blasts, in pros, promyelocytes, and also in reactive. I should have also said sometimes you see it in regular lymphocytes, so you can see lots of definitely prominent nucleoli on regular pro lymphocytes, but also in the mature lymphocytes, very little, inconspicuous. You can hardly see it. But if it's there, it's not, it's not weird to see very inconspicuous nucleoli on the cells. But these are what you would call your pro lymphocytes. All right, so let me go back to this, go back to the whole developmental process of the B cells, because we have to understand something very important about the somatic mutations, okay? So we have, for CLL, there is a diagnostic criteria, right? The one that I showed you before, that was developed by the World Health Organization. It's what hematologists would follow to basically diagnose their patient. But with that, there are also factors that we can consider for prognosis. So not only there's a diagnosis, but now we can place the patient into two categories. So we can say, all right, this patient has favorable prognosis in CLL, or they have a poor prognosis, which pretty much means there will be a poor outcome, and maybe the treatment needs to be a little bit more aggressive or whatnot, right? And so something that we need to explain is that there's the status of the somatic mutations in the immune globulin heavy chain variable region. Those mutations are very important because they give us an idea of how aggressive this will be. All right, so there's two types in terms of the immune globulin heavy chain variable region mutations. There's two things going on, okay? We have the MCLL, which is the mutated CLL. So that means that it's CLL with mutated IgVH, okay? This would put the patient in a favorable category. And then you have UCLL, which is unmutated CLL. And that is an unmutated IgVH. So that's IgVH stands for immune globulin heavy chain variable regions. Those are the somatic mutations that when the cell is maturing, it tells us where the antigenic specificity, okay? So there is mutated and there is unmutated, all right? So mutated, it's good. It places the patient in good prognosis. Unmutated, it's really not that good, okay? So each receptor on a B lymphocyte has a specific immune globulin molecule, as you already know, right? Each receptor will have 2 heavy chains and 2 light chains, and each heavy chain and each light chain has the variable region and the constant region. The variable region is what determines the specificity for a particular antigen. So in the bone marrow, hold on, let me just move this a little bit. The bone marrow, the variable region undergoes rearrangement, okay? And lymphocytes are the only cells that can undergo gene rearrangements. After gene rearrangements in the bone marrow, the naive B cells then travel to the lymph nodes. In the lymph nodes, when the antigen binds to the immune globulin receptor on a naive B cell, it undergoes antigen-induced, it undergoes what's called an antigen-induced maturation process, okay? And this antigen-induced maturation process can be either T-cell dependent or it could be T-cell independent, okay? This process, the T-cell dependent maturation occurs at the germinal centers of the lymph nodes. So when the antigen comes in contact with the B-cell receptor, the cell divides rapidly, and then the genes that code for that variable region of the immune globulin receptor undergo the process called somatic hypermutation. So that's what I was talking about before. Somatic hypermutations then result in many different B-cell progeny, and each of those cells have different affinity for the antigens, okay? And again, what I said before, the cells with the highest affinity for the antigen will proliferate, and then the cells with the lowest affinity will be eliminated. They will undergo apoptosis, okay? So that process is called affinity maturation. On the other hand, T-cell independent maturation is different because it occurs outside of the germinal centers and the marginal zone of the lymph nodes. So in this process, after the B cells bind the antigen, they will divide, but their immune globulin variable region genes may or may not undergo somatic hypermutation. All right, so with that said, in CLL, there are 2 prognostic groups, like I said before. They're very, very important. So the first group will correspond to the T-cell independent immune response with the B cells that show no mutations in the variable region of the immune globulin heavy chain, right? Or UCLL. And then the second group, which is the T-cell dependent immune response with the mutated variable regions of the immune globulin heavy chain, or the MCLL. All right, so that's where all of that is coming from. It's the UCLL or the MCLL, okay? So this mutation status, whether it's mutated or unmutated, is determined by PCR. It's determined by molecular diagnostics. So you can do it either by PCR, or you can do it. You can also do it by sequencing the DNA. So whether it's mutated or unmutated, okay. All right. So with that said, that's that's just I don't, don't worry about memorizing the whole thing, but just have an idea of like where that's coming from. That would be wonderful. So with that said, those are very, very important. Okay, so mutated immune globulin heavy chain or unmutated. All right, so mutated will give a good prognosis. Unmutated will not give a good prognosis. It is a more aggressive course of disease. Okay, so patients with unmutated immune globulin variable immune globulin heavy chain variable region have a more aggressive form of CLL, and then patients with mutated have a less aggressive form. Another marker that we take a look at in CLL is called ZAB70 expression. ZAB70 is a marker that is normally expressed in T cells. It's not expressed in B cells. In most patients, ZAB70 correlates with the immune globulin heavy chain variable region. Excuse me, correlates with the immune globulin heavy chain variable region mutation status. ZAB70 is found in high percentage in CLL individuals with unmutated IGVH genes, okay, which is poor prognosis. And the other expression would be CD38. That's assayed again by flow cytometry. This is more of like an independent predictor of the progression of CLL. In most cases, patients with CD8 expression will have a poor prognosis, and it will be a more aggressive disease. The other marker that we will look at in terms of prognosis is the lymphocyte doubling time, the LDT. And the LDT is the number of months for the peripheral blood absolute lymphocyte count to double in number. So individuals that have a lymphocyte doubling time that is less than 12 months will have shorter survival rates than those that have LDTs that are greater than 12 months. So those are really what puts them into good and bad categories. The ones that we know about, the ones that we can rely on. And that is basically for prognosis, but then you also have the criteria for diagnosis, right? That is slightly different, and that's determined by the WHO. So one test that we can do for prognosis in CLL is called the FISH, right? The fluorescent in situ hybridization test. This is a molecular test. There's different types of FISH. This is an example of interface FISH. And it's the best. FISH is kind of the best test in this condition to determine the chromosomal abnormalities. So chromosomal abnormalities need to be picked up here in addition to the other markers that we just talked about, because it also adds to the prognostic factors. So FISH consists of DNA probes labeled with fluorophores that are specific for areas that are known to be abnormal in this condition. So if we're talking about CLL, then we want to get those specific fluorophores for the specific DNA sequences. And so these DNA probes with fluorophores are hybridized directly to the interface cells on a glass slide. And after hybridization, after that process is done, the unbound probes are removed with some washing steps, and then the cells are stained for visualization under a fluorescent microscope. And so FISH is like a little bit time consuming, but it's not so bad. But we look for reaction. So we look for color. All right. So here's some examples of a interface FISH, for example. If we put a red probe on deletion of 17p, right? Or the green probe on 13q, after you do all the washing steps, you would see whatever you tagged, whatever fluorophore you tagged on the sequence, on the genetic part that you're looking for, okay, that's what comes up, and it's usually a fluorescent process. For example, if you look at interface fish of trisomy 12, this has been tagged with a red fluoroform, so you see 3 copies of the red what's it called, the red chromosome. Sometimes if you're looking for translocation, so what happens is that you tag one color in one piece of a chromosome, and then you tag another color in another piece, and when there is a translocation, it becomes a different color. So the translocation occurs and the 2 genes fuse, and so it turns into a completely different color. So that's how you know something has merged. That's how you know there is a reciprocal translocation there. But fish can be used to detect deletions, additions, and things like that, things of that sort. So with CLL, some more genetic abnormalities, mutations, and chromosomal abnormalities have also been found to be helpful in the prognosis. Basically, so the more that the science evolves and the CLL evolves, there's more genetic mutations and chromosomal abnormalities that have been identified, and so there are more prognostic groups that are found, which serve to identify the progression of the disease. So there's prognostic groups like high risk, intermediate risk, low risk, and also very, very low risk. Patients that are categorized in the high risk group harbor the TP53 mutation and or the BIRC3 mutation. So if you look at a 10-year life expectancy, patients that are grouped in this high risk group are 29% of that expected in the matched general population. CLL patients that are grouped in the intermediate group, they harbor the Notch1 mutation and or the SF3B1 mutation and or the 11q deletion of 11q mutation. So in a 10-year life expectancy, these patients grouped into intermediate risk group, they have a 37% of that expected in the matched population. So you can get an idea of what that's like. But the very low risk, the chances of surviving 10 years after diagnosis is a lot greater. So it's at almost 70%, right? So the mutations help to be able to put these patients into these categories and also to take action, right, with the treatment and the monitoring. All right. So chronic lymphocytic leukemia, in CLL, the cells are immunologically incompetent, and they are associated with autoimmunity and also hypogammaglobulinemia. The treatment for CLL is usually held until the clinical symptoms present. So you could have a diagnosis, and if the patient's not really feeling the symptoms, you don't have to do anything. But also that depends on the course of on the prognosis for that patient, right? So the following are indications for treatment in CLL patients. So if there's progressive bone marrow failure, if there is massive lymphadenopathy and or splenomegaly, if there is progressive lymphocytosis, if there is autoimmune hemolytic anemia or thrombocytopenia, fever, night sweats, weight loss, fatigue. So these symptoms would really prompt to say, okay, we need to really start ramping up the treatment. But normally a CLL, it would be like let's diagnose and let's see what happens depending on the progression of the disease. But as the symptoms start to appear and become more prevalent, then the treatment starts to vary and to change as well. So it really all depends on everything put together. There's other B-cell malignancies too. There's one called monoclonal B-cell lymphocytosis, NBL. And in this condition, B lymphocytes are less than 5,000. So it's not really the same as the CLL. There's also absence of organomegaly. There's cytopenias, which is a reduction in the number of the cells, and there's disease-related symptoms. And the reason why there's cytopenias, right? There's bone marrow. There's absence of cytopenia due to bone marrow involvement. There's also one called small lymphocyte leukemia lymphoma, SLL, and in this condition, B lymphocytes are also less than 5,000. They have pretty much the same immunophenotype as CLL. There is a lymphoadenopathy and the absence of cytopenias because of bone marrow involvement. There's B-cell prolymphocytic leukemia. B-cell, this is PLL. It could be B-cell PLL or T-cell PLL. For B-cell PLL, this is rare. It's a rare condition where you see mature B-cell, you see a mature B-cell malignancy here. It comprises more than 55% pro-lymphocytes. These are medium-sized cells with a round nucleus. They have moderate, abundant cytoplasm, and they have that distinct nucleolus. So it looks like it's punched out, like a little hole, like we punched a hole out, right? B-cell PLL is positive for CD19, 20, 22. In some cases, it's positive for CD5, FMC7, surface immune globulin positive. The white count's usually more than 100,000, and the median age of diagnosis is about 7 years, 70, not 7, 70 years. And this kind of mature B-cell neoplasm has very poor prognosis. All right, the next one is hairy cell leukemia. This is another one of the mature lymphoid neoplasms that we evaluate. In hairy cell leukemia, there are small B lymphocytes with abundant cytoplasm and fine cytoplasmic projections. I'll show you the picture in the next slide. The median age of diagnosis is approximately 55 years. And hairy cells are found predominantly in the bone marrow, and also in the spleen, the red pulp of the spleen. Only a low number of B cells are seen in the peripheral blood. You never really see a lot of hairy cells in the peripheral blood. You would have to look in the bone marrow. But because of these high numbers of leukemic cells, sometimes when you do a bone marrow biopsy, when you want to get a sample, it will show lots of reticulin fibers. So it kind of interferes a little bit with the bone marrow analysis. But luckily, there's immunophenotyping, so we can do flow on these cells. We can look at morphology, we can do flow. The immunophenotype will show co-expression of CD19, 20, 22, surface immune globulin. It will give you a nice and bright expression of CD11C and CD25 and 103. So those are the ones. So it has B cell markers, but it also has hairy cell markers, which is nice. There's also some immunohistochemical stains that we can do on hairy cell patients, but those are not required for diagnosis. Most important thing to do here is a clinical presentation, morphology, and immunophenotyping. But the stain is called a TRAP stain. It stands for tartrate resistant acid phosphatase. There's another one called the annexin A1 stain. So those are both positive. And also there's pancytopenia. So a decrease in the counts, the red cell, white cell, platelet count, and also there's splenomegaly in people that have hairy cell leukemia. So the next two slides will show you images of hairy cells, and you see that there's very fine cytoplasmic projections, and it makes it look like the hair is standing up, right? So that's why they're called hairy cell. Now, one of the things, so you want to follow up with immunophenotyping on peripheral blood. It'll probably be hard to do on the bone marrow because of the reticulin fibers. But one of the things that happens is that when you have a patient with CLL, you can count them in the instrumentation, right? But some of the hairy projections, cytoplasmic projections kind of like come off, and they're so tiny, they are kind of like the size of platelets, and they get counted as platelets. And so it could falsely increase your platelet count when you have a patient with hairy cells. So that's something that you just kind of need to stop and evaluate as well. So you'll be looking at the white count, you'll be looking at the hemoglobin, the platelet, and if it's hairy, if your platelet count seems to be off, then it's probably because some of these projections are interfering. So check the peripheral blood smear for, a falsely increased platelet count. All right, so more hairy cells here. And again, peripheral blood doesn't have that many of them, but they do seep into the peripheral blood, but you would see them also in the bone marrow. So they look like cytoplasmic frayed, cytoplasmic projections. And here are some more mature B cell deficiencies, but these are B cell lymphomas. So remember, lymphomas will originate in the lymphoid tissue, and they could seep into the peripheral blood and then eventually in the bone marrow as well. All right, so we have mantle cell lymphoma, we have follicular Burkitt's lymphoma, and plasma cell myeloma. So mantle cell also has some immunophenotypes. It's called mantle cell because the origin is the mantle zone in the lymph nodes, and there's also some cytogenetic expression involved. Follicular, they originate in the germinal centers of the lymph nodes. Burkitt's, it's also part of the germinal center, and plasma cell myeloma implicates plasma cells. So I'm not going to talk about mantle cell, follicular, or Burkitt's, but I'll show you some pictures. But we're going to focus primarily on plasma cell myeloma. So that's also known as multiple myeloma. So this is mantle cell lymphoma. Mantle cell lymphoma is characterized by medium-sized lymphoid cells with irregular nuclear outlines, and they derive from the mantle zone. And the other one is follicular, and follicular comes from the same thing. They're also medium-sized lymphoid cells, but they could be a little bit angular sometimes. Like if you see, they can come in a little bit of an angle, but not so much. Sometimes they have indented nuclei. So one thing to note is if we cannot tell what it is just by looking at morphology, which is probably going to be very, very hard with these kinds of lymphomas, what we do is we look at the clinical picture, we do immunophenotyping, and we can also do lymph node biopsy and some molecular tests. Okay, but morphology alone with these lymphomas is very, very hard. Okay. And this is a large B-cell lymphoma, very large cells, vacuolated cells. Again, very difficult to see. Morphology is not, as easy. This slide here shows you Burkitt's lymphoma. This is characterized by medium-sized lymphoid cells, and they have very basophilic, vacuolated cytoplasm. So it's very dark blue cytoplasm, and lots of vacuoles are seen in the cytoplasm. But Burkitt's lymphoma is positive for some translocations like 814, 28, or 822. And there's also the overexpression of the MYC oncogene, and positive for CD10, 1920, BCL6, and negative for CD5. The next condition is plasma cell myeloma. That's formerly known as multiple myeloma. And so the slide that I'm showing you here is peripheral blood and the bone marrow, right? So you see the peripheral blood, the bone marrow. The bone marrow has lots of plasma cells. You know by now what plasma cells look like. They are bigger cells. They have very basophilic cytoplasm. They have an eccentric nucleus, and they have a perinuclear halo, which is like a little clearing that goes around the nucleus. So you could see a few plasma cells in the peripheral, not that many. You would see a lot more in the bone marrow. And patients that have plasma cell myeloma are positive for CD38 and 138, and negative for CD19, 20, and surface immune globulin, because plasma cells are terminally differentiated. So it doesn't really have the B cell marker, but they have their own kind of, markers, because they're like, they've already been differentiated into plasma cells. So this slide shows us plasma cell myeloma. It is what happens in plasma cell myeloma. This is a bone marrow slide. There is an accumulation of malignant plasma cells in the bone marrow. And what they do is they present as as lytic bone lesions. In plasma cell myeloma, there's marked bone marrow plasmacytosis. So there's lots of plasma cells in the bone marrow. They usually constitute more than 30% of the marrow cellularity. The morphology is they're large cells. They have high nuclear to cytoplasmic ratio. They have dispersed chromatin, and they have distinct nucleoli. Plasma cells in the bone marrow, they form large aggregates and sheets. And then rarely, you'll see increase of plasma cells in the peripheral blood, but you do sometimes. But that's what a plasma cell myeloma would look like in a bone marrow slide. So lots of plasma cells, eccentric nucleus, perinuclear halo, basophilic. You see, this is like a typical plasma cell. Perinuclear halo, eccentric nucleus, basophilic cytoplasm. Again, more pictures of plasma cell myeloma, big cells, eccentric nucleus, perinuclear halo, basophilic cytoplasm. Not all of them are plasma cells, but there's a lot of plasma cells in here. And so this are some of the tests that we would do in plasma cell myeloma. We can follow up with some, we need a bone marrow evaluation, of course, because you're going to see them in the bone marrow. And we can do a serum electrophoresis, serum protein electrophoresis, or urine immunofixation. So plasma cells, what do they make? They make immune globulin, right? So there's going to be a protein deficiency. We can do a urine protein immunofixation as well. And so in most cases, monoclonal immune globulin, it's produced by plasma cells, and that's detected in the serum. We can also detect it in the urine, or we can detect it in both of them, okay? So when you find this monoclonal immune globulin, that's called monoclonal gammopathy. That's what you're looking for in a plasma cell myeloma. You're looking for monoclonal gammopathy. And these monoclonal proteins in form of a complete immune globulin are mostly IgGs. Sometimes they are IgAs, or sometimes you find clonal light chains that are seen in the urine or in the serum, and you find them as monoclonal spikes. Okay, so that's an image of a monoclonal spike. But this is very, very characteristic of a protein deficiency that you would get in plasma cell myeloma. Okay. So plasma cell myeloma is really, really interesting. It is a disease that typically occurs in older patients. The median age of diagnosis is approximately 70. Older, right? There's bone pain. Okay, it's in bone pain, and the pathologic features are directly related to the proliferation of these neoplastic plasma cells. So these plasma cells are taking over the bone marrow, so it's causing a lot of pain in the bone. These cells can also produce factors that cause localized bone destruction. So that's what lytic lesions are. They also cause hypercalcemia, high calcium. They cause renal insufficiency, and that's triggered because of the increased monoclonal proteins. They cause cytopenias because the bone marrow is infiltrated by plasma cells, so it can't make any other type of cell. There's also depressed immune globulin levels. The decreased immune globulin levels lead to susceptibility to infection. So there's no fight against infection, right? And high proteins and low albumin can lead to rouleau. So one of the things that you'll see in the peripheral blood too is the formation of rouleau because of the high protein and low albumin. It starts to form the stacking, the coin stack effect in the red cells. So there's a lot going on: bone destruction, bone pain, lesions, hypercalcemia, which is increased calcium. It leads to the infiltration of plasma cells in the bone marrow. Eventually, there's cytopenias, which can lead to anemia. Then you have immune deficiency because of the deficiency of the immune globulin levels, which can lead to infections. Hypercalcemia can also lead to renal failure, but the renal failure can also come from the high monoclonal proteins. And high proteins and low albumin can lead to rouleau. So these are just key factors that you want to look for in diagnosing these patients. So there's a working group. It's called the International Myeloma Working Group, and they established the criteria for plasma cell myeloma. And so the patient must have monoclonal, they must have monoclonal proteins in the serum or the urine. So whether you do serum electrophoresis or urine immunofixation, you have to find the monoclonal proteins in the urine or the serum, all right? Also, more than 10% monoclonal plasma cells in the bone marrow, and at least one of the myeloma-related organ dysfunction features. There's also known as CRAB. So CRAB stands for C is calcium elevation, R is renal insufficiency. So you're looking at the serum creatinine. We're looking at A for anemia. So you're looking at the hemoglobin, and then B for bone lytic lesions or osteoporosis. So you're looking to diagnose using this criteria. So definitely the monoclonal protein in the serum or the urine, more than 10% plasma cells in the bone marrow, and at least one of these organ related symptoms. So either the calcium elevation, the renal insufficiency, the anemia, or the bone lesions. And plasma cell myeloma is different than plasma cell leukemia. Plasma cell leukemia happens when the peripheral blood has more than 2,000 of the plasma cells, the actual absolute, or more than 20% plasma cells in the peripheral circulation. And then monoclonal gammopathy of undetermined significance means that there is less than 10% plasma cells and less than 30 grams of protein, of monoclonal protein. And then, of course, with, even though we have B cells, we also have T cell neoplasms, right? We have the mature T cell neoplasms. They can be, the mature T cell neoplasms can also be leukemic malignancies. So for example, you have the T cell prolymphocytic leukemia, the T cell large granular lymphocytic leukemia, aggressive natural killer cell leukemia, and then adult T cell leukemia lymphoma. Mature T cell malignancies can also be cutaneous. There's the anaplastic large cell lymphoma and the mycosis fungoides and Sézary syndrome. Mycosis fungoides and Sézary syndrome are cutaneous lymphomas that show erythroderma. So by cutaneous, what that means is that it involves the skin. So some of these lymphomas will affect the skin of the patient. So, for example, with fungoides, with mycosis fungoides and Sézary syndrome, this will show a rash, or like redness of the skin, exfoliate dermatitis, which is a rash, and this is seen in patients that are older, 55 to 60 years. Sézary syndrome is a disseminated disease with leukemic presentation and skin and lymph node involvement. Patient is positive for T cell markers, so CD3, 5, 2, CD4, but they're negative for CD7. Examples of Sézary cells, these are medium-sized lymphocytes, but they are malignant cells, and they are known to have cerebroform, so they have very convoluted nucleus that resembles kind of like the convolutions of the brain. That's why they're called cerebroform. And then lastly, we have Hodgkin's lymphoma. Hodgkin's lymphoma can be divided into two broad categories. There's the nodular nodular lymphocyte predominant Hodgkin lymphoma, and then there's the classical Hodgkin's lymphoma. The nodular lymphocyte predominant Hodgkin lymphoma is a B-cell neoplasm. It's rare. You see lymphocytic, histiocytic cells. They're also known as the little popcorn cells. They have there's normal architecture of the lymph node. The normal architecture of the lymph node is replaced by nodular proliferation of small lymphocytes. And these popcorn cells. These cells are positive for CD20, BCL6, and immune globulin chains. And most patients that have this are male patients. And they could be young, like 15 to 35, 34, 35, and then older than 54 or 55. Same thing with the classical. You kind of see it in the same range of the age group. It's like the classical Hodgkin's lymphoma is actually a group of lymphoid neoplasms that derive from the germinal centers. Again, prevalent same age groups as the non-classic form, and it is characterized by the presence of Reed-Sternberg cells. They have a reactive background. So Reed-Sternberg cells have two nuclear lobes, and they have very distinct nucleoli. And there's 4 different subtypes of this classical Hodgkin's lymphoma. There's the nodular sclerosis, the mixed cellularity, the lymphocyte rich, and then lymphocyte depleted. So what's interesting about these lymphomas is these types of lymphocytes. Look at this, like it has double, like 2 nuclear lobes. So they're known as the Reed-Sternberg cells. All right, so that ends my lecture, mature lymphoid neoplasms. If you have any questions, please let me know. I'll stop the recording.